Okay, thank you. Hello, everyone. I'm Dale Kim from AOSIN Medical Center in Korea. It's a great pleasure to attend the wonderful online AOSIN 2021 and have a chair this session. Let me introduce Cheng-Chia, next speaker. Dr. Cheng-Chia got a PhD at Institute of Brain Science and Neuroscience in National Yangmin University, Taiwan. And he was trained and he has served clinical fellow in the Department of Neurosurgery, Neurological Institute, Taipei Veteran General Hospital. And he has experienced in research fellow at the Department of Neurological Surgery, University of Virginia in 2014. Now he has served attending position in Department of Neurosurgery, Neurological Institute, Taipei Veteran General Hospital. And he has served the Secretary General in Taiwan Society of Stereotactic Functional Neurosurgery and Radiosurgery. And he has organized the Secretary General in AOSIN 2021. The title of the topic is the Intra-operative Neuromonitoring for Epileptic Surgery. So Dr. Lee, please.
Thanks, Mr. Chairman. It's my great honor to be here to participate in the AOSIN virtual meeting. Today, my topic is intraoperative neuromonitoring for epilepsy surgery. This work is coming from Taipei Veteran General Hospital. In the past 13 years, we perform many kinds of epilepsy surgeries, such as anterior temporal lobotomy, selective amygdalo hippocampectomy, either transcranial or supracerebellar, insula and singular gyrus legionectomy, also calcotomy and hemisplenectomy. Invasive EEG recording including subdural grid implantation and SEEG implantation. For all kinds of epilepsy surgeries, we need several advanced microsurgical techniques, including accurate navigation system with functional images. Microsurgical instrument with good resolution of microscope is also necessary. Of course, we need comprehensive intraoperative neuromonitoring, and most importantly, the surface and the deep electrodes for the echo. Taipei Veteran General Hospital began the first epilepsy surgery program in Taiwan since 1987. Professor Shi, our program director, developed a large epilepsy surgery team, including neurologists, neurosurgeon, pediatrists, intraoperative monitorists, and a functional neurosurgeon. By using ECOG, EP, SEP, brain mapping, microscope, lead cell frame, robotic arm, and radiofrequency ablation to manage various drug-resistant epilepsies. Someone may ask why we need ECOG and other intraoperative monitoring technique. There are several reasons to determine the site and the border of the epileptogenic zone, to decide the post-surgical outcome. From 2000, we began to perform intraoperative ECOG. However, we find several weaknesses when we perform intraoperative ECOG. We can only identify the intra-ictal spikes, which means we can only identify the irritative zone, not the seizure onset zone. The recording time is usually limited around 10 to 30 minutes, and finally the seizure could be underestimated due to the blood suppression under general anesthesia. Therefore, in current clinical practice, we prefer to perform the intra-operative echo more frequently. Since 2014, we have periodic shifted to stereo EEG for intra-operative recording. However, we still preserve several intra-operative neuromonitoring techniques, including central sulcus localization by the SSEP and NEP for the motor cortex monitoring and the shifting of the cortical spinal projection, and of course, awake craniotomy for the language mapping. By using the subdural grid strip and depth electrode, the goal of the IOMM for the epilepsy surgery can be achieved. Find the epitogenic zone and perform the functional mappings. Let's talk about some basic concepts of EEG recording. What's the EEG? The EEG is a graphic representation of the difference in voltage between two different cerebral locations plotted over time. So what is the scalp EEG? The signal coming from the several neurons and pass through the pyometer, subarachnoid space, arachnoid, dura mater, stubble, and scalp. And finally, these signals were collected by an EEG electrodes. Via EEG amplifier, we can read them through the monitor. However, the diameters of an electrode is about 1 centimeter, which can collect 3 centimeter size signals. And one neural signals can be collected by adjacent EEG electrodes. Therefore, the scalp EEG is not always clean. It's interfered by several contaminations, such as muscle, eye movement, and adjacent gyro structures. So we always say the EEG is a summation of the temporal signal. Although the scalp EEG has very good high resolution, but usually have relative poor temporal resolution. So always keep in mind the the EEG signals is modified by the electroconduction property of the tissues between the electrical source and the recording electrode on the scalp, and the conductive properties of the electrode itself, the orientation of the cortical generator to recording electrode, the distance of the cortical generator to the recording electrodes. From the comprehensive EEG investigation, we need to define the terminology, location, and montage from communicated signals. The 10-20 system is the most popular method. From the nascent to Indian, 10, 20, 20, 20, 20, 10 percentage distance from each to each. Two montages were used more frequently. We call bipolar montage or reference montage. The reference montage means that all the electrodes were compared to reference electrodes, and it is easier to find the highest amplitude. The bipolar montage is side-to-side comparison. The phase reversal is usually the focus of the signal origin. This is a reference montage. The reference is CZ, tops of the head. You can find the highest amplitude is located in the FA. This is a reference montage, and the reference is CZ. Also, you can see the largest is FA. When the same signal transfer to the bipolar montage, double banana montage, you can find the phase reversal is located in the FA, and we can say the epileptic discharge may come in from FA. So there are several criteria for the spike and the shock wave. It has been outstanding electrical field biphasic asymmetry, usually negative polarity with after-going slow. Spikes usually less than 80 milliseconds, and the shift wave is ranged from 80 to 200 milliseconds. And we also identify the frequency of the EEG waves, especially beta, alpha, delta, delta. We also identify the gamma, high gamma, and the gamma, high gamma were also related to the functional test. And sometimes it means this phase activity is a biomarkers of the ethos spreading. So for example, the evolution of the ethos propagation from beta to gamma and progress to the high gamma. This is a focal spike. You can see very sharp, high amplitude. In bilateral hippocampus, you can find the phase activity between the intermittent spike and the fast and the transient. Sometimes we need to open the filter to cut the low frequency under than 18. This kind of high frequency oscillation is usually related to the pathology, and it means somehow it's an epitogenic focus. In recent years, we are routinely to identify the high-frequency oscillation, which is a biomarker of the epilepsy focus. So let's see a test demo. This is a 4-year-old, near 5-year-old male patient, and is a 1-year-old onset. He had no aura. When it onset, he will stop his activities, laughing or not. And usually they have a right side limb, some elementary movement, and no confusion after it onset. The duration is about 2 to 3 seconds. The frequency every day, maybe 10, maybe 7. He took 4 medications, so it's definitely is a drug-resistant epilepsy. After he treated, showed negative. And you can find the patient, the ethos onset, laughing with right side elementary movement, and he cannot control it. And he fell down frequently. Although the conscious clear, the boy cannot stop laughing and continuous right hand body in uncontrolled movement. The MRI grossly normal. And for this kind of motor onset semiology, we will try to find some lesions in central rolantic area. However, you can find nothing. A small, very small encephalomalacia was noted, but since not related to the seizure semiology. And if you look very, very closely, you can find in the PET very small hypermetabolic lesion in the left paracentral lobe. However, the MRI showed nothing. Stop EEG only show the few F3 spikes and the CZPZ by transverse montage, not in reference or double banana montage. When the clinical onset, the EEG change is not obviously, and some rhythmic changes over left frontal central area, with some evolution of left frontal central rhythmic theta and delta activity. When the seizure stops, the rhythmic delta activity will also stop. So in summary, this is a right limb elementary motor seizure with laughing, MRI negative but PET positive. EEG show the left frontal central onset seizures. So we prepare the phase 2 study with the SEEG. We have 3 goals. We have localize the epigenetic focus and confirm the boundary. And finally, we need to map the electron area. So this is our SEEG planning, and this the blue circle is a PET-low area, and the yellow one is a cystic lesion. And you can see the design including the motor area, the frontal area, and also very superior frontal gyrus. And of course, because it's an elementary motor, so we suppose the lesion is nearby the E or G. And similar to the stop EEG, we find phase activity increase and attenuation on the electrode G1 and the G2 when the seizure onset, and gradually affect to the adjacent electrodes. After seizure, the slow wave will be dominant in the most of the electrode, and it will also perform the functional mapping. We can reproduce the ETO symptoms when stimulating the electrode G1 and G2. So it's very important because we can reproduce with low frequency stimulation. So this is when we map the G1, G2, and after stimulate, you can find his regular, you can see here, you can see the habitual seizure can be reproduced. However, the adjacent electrodes, the G3 and the G4, has also motor function. You can see when after stimulate, the patient have some hand dystonia, and then the patient will hold his another hand. It means the epileptogenic lesion is just close to the functional area. So it's very, very critical area. So let's detail the area of G1 to G3. It's just located in the paracentral lobule. So why is paracentral lobule? The neurons in paracentral lobule are considered to be motor and sensory innervation of the contralateral lower leg or lower extremity. And the regulation of the physiological functions such as defecation and maturation is highly functional area and a very critical area when performing the surgical resection. So we know the brain plasticity may happen in some pediatric patients. Unfortunately, the plasticity is not present in these patients. So how we perform the IOMM in this patient? We prepare the phase reversal with the SEP and the NEP, continuous monitoring, and including the D-wave, cortical mapping, and the subcortical mapping. So we plan to reset the green area here. And you can see the when we perform the craniotomy, the anterior here, posterior here, midline, and the lateral, and the strip is just on the left motor cortex. And you can see we finally reset the area and stop due to the motor response under the 1 milliampere subcortical stimulation. It means it's very close to the motor fibers. And you can see our phase reversal for central sulcus localization, our continuous NEP recording, although the NEP is not, the amplitude is not large, but still can be monitored. And when we perform the subcortical mapping, you can see initially we can use a low risk threshold is 6 milliampere. However, after it's very, very close, it's 1 milliampere. So we stop to reset here. Although the patient had no motor deficit, unfortunately the seizure was not improved and even more severe. So we arranged the second resection surgery and prepare to operate and reset more anteriorly. Similarly, we still prepare SEP and EP, cortical mapping, and subcortical mapping. And from the previous study from our hospital, we are try to perform the intraoperative brain mapping to identify the cortical projection. And if the patient can have a brain plasticity and one cortex, one motor strip can innervate both sides of the hands or legs, we are very safe to reset the lesion site. However, if the lesion site innervate the contralateral hand and the healthy side innervate both hands, I think it's also safe because you reset here, the healthy side can innervate both. However, if the healthy side only innervate the contralateral side, and when we perform the lesion side, you may lose the function of the hand and legs. In our case, unfortunately, the same as a functional MRI, the patient had no shift of the cortical spinal projection. It's just like I say, it's unlucky. So again, in this case, face reversal for central sulcus localization, and this time is more beautiful, and NEP baseline is small, but still can be monitored. The operation went smoothly, and we reset more anterior. After the second operation, the patient had mild right leg weakness. Until now, the patient is already 2 years, and the patient had seizure-free, and the pathology showed the FCD type 1B. So this is a boy, is very healthy now, a little bit weakness, but still, the patient has seizure-free, can dance, can run, and his cognitive function is much improvement. So it's a very happy ending, and the other important issue for the epilepsy is functional mapping, and by several SEG electrodes, we can explore the function of several deep brain areas. For example, the insula. Here, I try to use few slides to explain our work in insula function exposure. As we know, the insula is composed by 5 gyrus, 3 gyrus, and 2 long gyrus. And sometimes there is a sensory insula gyrus around the insula. There are limiting structures, including the anterior, superior, and the posterior. Coronally, you can see the structure beneath the insula, including the claustrum, internal capsule, putamen, and the globus pallidus. It's not easy to recall the EEG signals from the insular cortex. And usually, we will see a large field of the abnormality, but you are difficult to say the signal is coming from the insula. So, we still face several insular epilepsy in the clinical practice, but how can we confirm it? In the past 5 years, we put 300 electrodes contacts into insula, sometimes 2 electrodes into short and long gyrus. If we need more exploration, 3 to 4 electrodes will be arranged to put in posterior long or anterior short gyrus. These procedures can help us to identify the seizure onset, and we can perform functional mapping too. This figure is showing that from the monkey study, the cortical and subcortical projection may imply the function of the insula. For instance, the external receptive sensory, including visual, auditory, and vestibular, we can see the projection fibers from inferior temporal cortex, A1, A2, and auditory cortex. For interoceptive or visceral sensory, we can find the connection from the gustatory, nociceptive, and the thermoreceptive sensory. Of course, somatic movement is related to frontal orbicular and the lipid motor fiber is related to the ACC. From the figure shown here, we can image the function of the insula is based on the 3-belt distribution, not anatomical 5 gyrus. And from the investigation of the intra-epilepsy patients, we find some semiology may come from insula. As we know, the laryngeal contraction, paresthesia in premotor region, and the lateralized somatosensory symptoms and the focal somatomotor symptom. So why insula is so important for epilepsy? Not only because they generate various eto symptoms. Some are more specific and some are more like temporal, frontal, and parietal onset. So it's a great mimic. Sometimes we are difficult to identify the insular epilepsy. And the failure to recognize and identify insular seizures may explain why patients continue to experience seizures following epilepsy surgery. Insular recession cannot, based on the echo spike alone, confirmed by intracerebral recording, is necessary when insular seizures are suspected, especially if there is no lesion on high-resolution MRI. This is an example of the insular onset epilepsy from anterior shell gyrus of the insula, have a fear and an emotional component. Short-term onset with tonic phase. It's very short seizures, but we can see the frontal mimic and temporal mimic seizure presentation. And we put SEEG here, and once we can identify, we can ablate the lesion by radiofrequency ablation. So intracerebral electro stimulation of the two goals, reproduce the eto clinical expression and perform the functional mapping of the regions explored. Our protocols show here, including low frequency and high frequency. Here is some example. We stimulate the axis. The patient had a feeling of rising from the spine. And another case is stimulate from the right S4. The patient had the feeling of a strong soundness. And also, this is a left S4 in anterior long gyrus of insula. So the right hand drops when asking patients to hold her upper lip. So totally, we have 28 patients with 307 electrodes within the insula, speech disturbance in 3, and somatic response in 113, and overall pharyngeal response in 33. And the pain in 6, motor response in 25, auditory response in 9, and others. Deja vu, visual hallucination, fear and palpitation, objective approaching, and nausea. And the video show the patient experience fear and palpitation, and we stimulate here. And in summary, the positive rate is high when mapping the insula. We saw that the insula is a silent area in the past, however, it's not at all. So let's look these numbers. We had 307 contacts in insula, and the 204 contacts had positive response. Near 2/3 the contacts can be stimulated positively. We can also find the more posterior gyrus, the more positive stimulate can be found. So this my today's talk. In summary, we believe the simultaneous ECOG and ECOG is routinely used in our current epilepsy surgery, and some difficult cases with deep lesions were not easy to approach. Using the intra-operative SEEG is necessary. And a functional mapping can be provide more information in the further neuroscience and clinical practice. So thank you for your attention.
Okay, thank you, Dr. Lee. Nice to meet you.
Hi, I see you again.
Yeah, okay. Thank you for the wonderful presentation about epileptic surgery. So now it's time to discuss for a brief time. So let me read the question in chat box. So in patient with congenital hemiparesis and schedules to undergo hemispirectomy, will you routinely define the pattern of corticospinal projection beforehand to avoid post-operative more weakness of the already affected limbs?
If the patient is planning to do the hemispherectomy, actually the most patient is less than 3 years old. So actually it's not necessary to test the the bilateral innervation. But however, if the patient is larger than 3 years old, maybe pre-operative NEP test, I think it's necessary. But currently in our clinical practice, we will use the functional MRI because we think the functional MRI is actually is quite accurate. So yes, we do some, but not everybody. And I think the functional MRI can tell some information to us.
Okay, thank you. So there is another question in chat box. So I have one question. So
yes,
I think so. The real purpose of epilepsy surgery is the so cessation of epilepsy.
Yes.
So
yes.
and find the epileptic zone. So it is also important to the to prevent post-operative neurologic deficit. So I wonder, post-operative outcome, for example, so neurologically deficit after epileptic surgery. Could you explain that? Okay.
Great. Every time I think if the abductor region the focus is very near to the functional area, we were supposed to do the phase 2 study. For example, the subdural mapping or SE. Currently, we prefer to do the SEEG mapping. And of course, intraoperative, we can test the motor and the sensory function. But for the language function, it's very difficult to perform the language test very comprehensive. So for the language test, I will prefer to do the subdural or SEEG mapping. So I think it's a trend. I think in the future, intraoperative language mapping will be less. And of course, in my last part of the insular mapping, you can see because it's very deep and the function is not so consistent. So in that area, very deep area, we will suggest to do the SEEG mapping for a better functional exposure.
Okay, thank you. Thank you for the wonderful presentation. So, Professor Su, so please close the session. Okay.
Yeah, I would like to thank Professor King for co-chairing this section, and also thanks both speakers, Professor Kodama and Professor Lee, and to giving us very excellent lectures. And please stay tuned. And right after this section, we will have a lunch time, but it's another lecture by Professor Zhou Ye. And I would like to close this section. Thank you very much.
Thank you.
Thank you.